with many of these new therapies that have come available for patients with CLL, one of the questions that is that many of you may ask or read about is how well do these new therapies do for my disease? Ibrutinib, which is a very good therapy, if we look at responses, so this is very interesting, if you look at responses to ibrutinib, so you can have somebody who's been on ibrutinib for years, but if you do their bone marrow, they still have disease. Technically, they're not in a complete remission because there's still evidence of the CLL in their bone marrow, but their numbers may be great, they may have no more lymph nodes, and they're doing fine. There's nothing wrong with that. As we are looking at some of these newer therapies, though, we know that, for example, venetoclax, which is a BCL2 inhibitor, we know that we can, with that drug, eradicate or get rid of your disease in your bone marrow a little bit better than if you're on ibrutinib as a single agent. And so we can mop out the bone marrow, and people can achieve a complete remission, at least at a higher frequency than patients who are on ibrutinib monotherapy. Okay, so in other words, ibrutinib has lower complete remissions than venetoclax. Does that mean it's a worse drug? We don't know that because patients are doing well for years and it has transformed and improved survival. But when we talk about drugs like venetoclax, then we're looking at, can we combine venetoclax with drugs like ibrutinib or with other drugs? And can we get people off of these oral therapies? So we were talking about taking ibrutinib indefinitely until you have a side effect or your disease progresses. With some newer agents or combinations of these agents, can we get people off the pills so you don't have to take them indefinitely? And so that's where we're using this detection, they call it minimal residual disease, or looking at finer levels of leukemia cells that might be floating around in your body. Can we use the detection of how much leukemia is in your body as a way to stop these therapies? And so this is where the field will be moving towards. So for those of you right now who are taking some of these therapies, you right now might be taking them indefinitely, but our goal is to see whether or not we can look at truncating or fixing the duration of your therapies so that you can get a break. As long as it works and you have a nice response to therapy. So I think the field will be moving forward in that direction. This is an exciting time for patients with CLL. I think for individuals listening to this, it is a hopeful time. There are many active therapies available now. We're looking at ways to make them better, safer, less costly, I hope, less toxic, and hopefully limited as well. So the field is really drastically moving forward at such heightened pace compared to the days of chemoimmunotherapy. I think you all have a lot of reasons for hope. And keep the dialogue open with your physicians. There is, you have questions, ask your physicians. If your physicians can't answer them, there are others who can. Seek comfort for those of you who like to get involved in patient advocacy groups or at least reading. There are many available to patients, so there are many support groups available to patients with CLL. So take advantage of that, or for the caregivers of patients for CLL. I think that's very important as well. But you have many reasons to hope and many things to look forward to.